Hi, my name is Shahina Dawood and I'm a consultant medical oncologist coming to you all the way from the United Arab Emirates here in Penang, Malaysia at the Asia Pacific Breast Cancer Summit 2026 with my co-chair, Rebecca Dent. Rebecca, please introduce yourself.
Great to see you, Shahina. My name is Rebecca Dent. I'm a medical oncologist at the National Cancer Center in Singapore, as well as a professor at Duke NUS Medical School, where I've been for the past 15 years. And Shahina and I are very honored, along with Dr. Lee Suchin, to chair the Asia Pac Breast Summit here in year 14.
Yes, absolutely. We're growing old together, Rebecca.
Absolutely.
So, Rebecca, you do a lot of work in the realm of triple-negative breast cancer, specifically metastatic triple-negative breast cancer. In your opinion, in 2026, what are the unmet needs for patients with metastatic triple-negative breast cancer?
Well, since we're old friends, I think we can remember when, I remember you did this fantastic paper and presentation on, years back when triple negative wasn't even a thing. And then I remember you did this publication where you showed the PubMed,
Yes.
references. And I think it is amazing to watch when you and I first started practicing, there wasn't a guideline for triple negative.
Absolutely.
We were advised just treat triple negative like any other sort of HER2 negative breast cancer. So, even though people still think of it as, a very aggressive type of breast cancer, which it is, so as it, on its own, triple negative breast cancer is an area of unmet need, no matter whether it's curative or whether it's metastatic. But I think we've come a long way in that right away we have our own guideline, whether it's NCCN, ESMO, ASCO. It's amazing to see that we now have guidelines specific triple negative, and now we have the advanced breast cancer guidelines that Fatima Cordozo publishes. So what are the unmet needs? So I think one is the PD-L1 negative population. We now have PD-L1 positive breast cancers where we can give immune checkpoint inhibition. We have germline BRCA or even somatic BRCA and PALP-2 where we can give PARP inhibition and potentially some other treatments that are in development. But I would say the PD-L1 negative are an unmet need. One, because we know they actually don't do as well, irrespective of the type of treatment, but it means they have no target. And so we know that that's an unmet need. We know that early relapsing is an unmet need. And I would say patients with brain metastases are an unmet need. That unfortunately does comprise 70% of patients with triple negative breast cancer.
Absolutely, and over time, we've seen newer therapeutic modalities actually enter the realm of their therapy, making their overall prognosis much better, but still not as good as we would like it to be. So you've done a lot of work in terms of antibody-drug conjugates actually entering the therapeutic realm of these patients. In that second-line setting, we now have SG that's approved and in the guidelines for patients with metastatic triple-negative breast cancer. Can you walk us through the ASCEND study?
Sure. So before I do that, I think it's important to comment about how the landscape has changed. So as you said, things have developed. So, when a patient's been treated with neoadjuvant therapy and often get the Keynote 522 regimen, by the time they see us in the metastatic context, it's a scary place to be.
Absolutely.
Right? So it's really exciting to see that we now have, I think the first in its class and the first to be published was, the CENT data, looking at an antibody drug conjugate versus standard of care chemotherapy. And I think that the first ASCENT trial was so pivotal because I think one, it was the first TROP2 directed ADC to show a survival benefit, which was really quite astounding. Number two, I think we realized that nobody knew what the standard of care should be. And so I think it really changed, not just for triple negative, but I think many other trials now have realized that, we often don't know what the standard is. And because the curative therapy is changing so rapidly, we have to be continually changing what the control arm is. So I would say the landmark ASCEND trial for, patients beyond first line was quite, remarkable because it allowed us flexibility. And so I think we're all super excited to have an option for patients because what we know about TROP2 ADCs, and especially we'll say sacituzumab, we know have Dato-DXd, we have sac-TMT, we have numerous other, ADCs. The payload is a topoisomerase 1 inhibitor. And we've known going back 20 years that the active metabolite of irinotecan is
SN38.
Exactly, it's SN38. And so I think it was Edith Perez and others did studies years ago that said, this is actually a very active compound in breast cancer.
Absolutely.
And the only reason we didn't give it to breast patients is because to give it at full dose was really toxic. And so the antibody drug conjugate, allows us to give a potent drug at much higher doses. So that's why I think the ASCENT study was so remarkable, looking at sacituzumab govitecan, and I think that was really a lesson for the future, for we can give drugs at higher doses, drugs that we normally can't give. And so I think we were all quite amazed to see the landmark study where we saw improvements in PFS, response rate, and overall survival. And that's why it was the first, ADC to, get into the guidelines for triple negative breast cancer. And I think what's happened since then is we now see these drugs moving into first line. We see them moving into the residual disease space. We have a number of ongoing trials looking at giving TROP2 directed ADCs for the residual disease, but also in the curative setting as well. So I think it is an exciting time for triple negative breast cancer.
You very rightly pointed out that a lot of these patients would have received Keynote 522 in the neoadjuvant setting. Irrespective of their PD-L1, they would have gotten pembrolizumab. And when they have residual disease, they generally tend to do very badly. Now, the ASCENT didn't really have those patients enrolled in that study. Is it reasonable to give SG in those patients who relapse on Keynote 522? And will it work?
Well, so ironically, the eligibility for the ASCENT, very similar to the Amelia trial in the HER2 positive space,
Absolutely, yes.
actually allowed for patients, they actually went in as a second line therapy. So if you actually look at the eligibility for that study, I've asked for those results of like, how many patients did we have that relapsed, were early relapsers and then were enrolled as sort of a second line. I don't know how many patients there were, but there were patients, just like the Amelia study and looking at TDM1 in that second line setting. So when you have a patient, that relapses like that, we know that, this is a different compound, its mechanism of action is different. And we now have 2 studies, at least, maybe 3, that show us that, ADCs seem to work in patients that have had, extensive therapy. So I think absolutely, right now, hopefully not everybody's listening, but we can bend the rules a bit. And if patients, relapse, this is a different mechanism of action. This is, important to give something that's different, because if a patient's had Keynote 522, they've had taxane, they've had a platinum, they've had an alkylating agent.
Absolutely, these are patients.
And many of them have had capecitabine as well, right? So I always say to regulators when I go to meetings, I say, these are heavily pretreated patients. We can't really call them second line. Ironically, they've had a lot of drugs. So I absolutely strongly feel that we should be moving our better drugs up earlier.
There's this misconception in the community that antibody drug conjugates like SG are not chemotherapy, but it is chemotherapy. And we need to be prepared in terms of how to handle the side effects and counseling our patients about it. So if you have a patient sitting in your clinic that you're about to start SG, how do you counsel them and what do you do in preparation for the side effects?
So it's a great question. So I agree with you. It is chemo. It's just a novel mechanism of delivering chemo. So I always say to the patients, I've got a smart bomb. They really like to read. I talk about the Trojan horse. We've got some chemo that's sort of hidden in there that's going to go to those TROP2 overexpressing cells. And I think one of the big mysteries is why certain ADCs have side effects versus others. And I think that's the mystery that maybe somebody can explain to me one day. But certainly, I think, if you're giving, sacituzumab, the main side effect that we look for is myelosuppression and infection. And, I think we've gotten pretty good at managing that. So if we can prophylax, I think that's one thing that as experienced oncologists, we kind of know how to prevent.
Absolutely.
And so, yes, I'll be honest, I usually give GCSF prophylaxis for all my patients. I don't wait for them to have it. And then what's nice is that, it's not expensive anymore and I can titrate it. So there are some patients that do fine. And even I sort of cut back the GCSF. There are some that I realize, need a little bit more. So often I'll just do 2 days and 2 days. And if they do great, then I'll try to tailor it down to 1. If their counts are borderline, then I'll up it to 3. I'm hoping, I think there is an ongoing study now looking at day 1 and day 14. And I think we know that the SAC-TMT compound is day 1 and 14. So I don't know the magic sequence, but I think the bottom line is GCSF for me is a must. I think certainly there are pharmacogenomic differences. We know that in Asian patients, they seem to get a little bit more myelosuppression.
Yes.
Not so much diarrhea, to be honest, but GCSF is now available widely. Patients can do it themselves. I think it's definitely worth it. So that's the number one thing that I would say that I prophylax, and I don't wait for something to happen.
So there's been a lot of discussion about the fact that diarrhea is also very important with SG, but at least in our part of the world, my part of the world, I don't see diarrhea that much, but I still educate and I keep that Imodium ready in case they need it. How do you counsel, and what's your experience with the diarrhea associated with SG?
So like you said, I find it's very heterogeneous. I mean, it's like every drug we give in oncology, right? Like there's some that you give AC and you're like, you prepared them for the worst. And then they kind of look at you like, why did you get so excited like this? You didn't have a lot of nausea. And then other patients, despite some of our best supportive care, still have a lot of nausea. So I think it's kind of the same thing. I prepare them for the worst, but I think it's a lot about education, right? You have the Imodium on hand. I actually very much counsel patients, no matter what drug they're on, to keep a diary. First, especially for the first 1 or 2 cycles of any new drug. Because by the time you come back to see the doctor, you don't actually remember what happened. And I can't help them unless I know when they got it, how bad it was. And I always remember one of my patients, I said, okay, maybe we should dose reduce. And she said, why would you dose reduce? I'm fine, I'm managing it. And so sometimes our impressions of what they're experiencing are very different. And that's where, patient-related outcomes, looking at PROMs. But I think certain tools, the easiest thing is they've got a piece of paper, write the day of the week, did you have diarrhea? And if you did, what did you take? And so then when they come to see you, you know exactly what happened. And that's the same for any new drug that you're, like if it's nausea or whatever it is. I think it's really helpful for patients to be able to communicate back, and otherwise they forget.
Now in that second line setting, what if your patient had HER2 low disease and you now have the option of TDXD and SG? How do you approach that patient?
So, I think it depends on many things, right? It depends on, I talk to the patient. I think there are certain countries where you have limitations. So if it's HER2 low, you can't give both. You can only give one or the other.
Okay.
Some of it comes down to schedule. Some people like the every 3-week schedule. I have a lot of patients that are worried about the ILD with TDXD, so they prefer SASI. And then I have certain patients that, they like the attractiveness of the TDXD, so giving that every 3 weeks. And so it really just depends on the patient profile. I think recently there was some data looking at TDXD and, in those really early relapsers, like 6 months on adjuvant or metastatic CDK and endocrine, they seem to, get a lot of benefit. So that's the space. But to be honest, I think SASI is probably effective in that space as well. I think, to be honest, that's where I think, especially in the ER positive space, I think we need to really think about moving ADCs up earlier. I think we've all been a bit shy too because we have so many other options. But I think in those patients that are sick, that you realize they've probably gone through, EMT, their breast cancer has transformed, is more aggressive now. I think we shouldn't be waiting. I think we should be using the ADCs if we can afford it, because I've seen so many metastatic ER positives turn around. Like I really thought that was it, but ADCs we're turning them around in a way that traditional chemotherapy couldn't. So it's taken me a while to sort of, try to encourage it a little bit more. But I think whether you're giving SASI or whether you're giving, TDXD, I think we do have to think about when those cancers transform, they need something different.
So if you had a patient, an ER/PR negative, HER2 low metastatic breast cancer who's relapsed on first line setting, say suppose that patient got capecitabine in the first line because she didn't want anything else, and she's in impending visceral crisis, like her liver is studded, her liver enzymes are beginning to go up, and it's not going to take long before she tips over. What are you going to use at that point, and what are you comfortable using at that point?
Am I going to call you?
100%. We'll have that discussion.
So first line, they are ER/PR negative, HER2 low. And what did they get first line?
Capecitabine.
Capecitabine. And they're PD-L1 positive or PD-L1 negative?
They're PD-L1 negative.
Okay, so they're basically a triple negative, but they're HER2 low, right?
Exactly.
Well, that's exactly the space for sacituzumab, right? Because they've had first line therapy, and the bottom line is, I think there's a larger data set in favor of sacituzumab, right? Like I think we all think that HER2 is an active drug in TNBC, but the problem is it's a very small number of patients, right? And so if you've got one drug, I think many of us reach for sacituzumab. If you have an ER positive HER2 low, I think some of us tend a bit more to TDXD. TNBC, but I think SASI is still a good option in that space. So I think we do sort of tend to go both ways, but certainly in our triple negative HER2 low, I think many of us will go for SASI. I think the hard question is, how do you sequence everything?
Absolutely.
And it depends how big your pocketbook is. Because I think, what I've seen is in all the data sets that have been done, obviously we have prospective data that our colleagues at Dana-Farber are doing and other groups are doing. So, when you look at the data, whatever the drug you use first works better.
Exactly.
And then whatever drug you use second doesn't seem to do as well. But then there are these outliers that are going to continue to get us to sequence.
Absolutely.
Because some of them haven't responded to their first line, or some of them responded well. So there's no predictor of who's going to respond well to that second one yet.
Yeah.
I mean, I think there are biomarkers emerging that I think are going to help us highlight who's becoming resistant. And I think the focus of resistance is a lot more complicated than we thought. But yeah.
But if you have a patient sitting in your clinic where money is not an issue and there's no barrier to what they can receive, and you've given first-line sacituzumab, are you going to give a chemo break or give them chemotherapy and then go on to an ADC, or do you think you might just do TDXD straight after SG?
So I'm kind of inclined to give a chemo break in general. Mm-hmm. And that really comes from Angela Brody's work on ER-positive disease, where she looked at endocrine sensitivity. I mean, a totally different cancer, but the concepts of the fact that under selective pressure of treatment, that cancers change and try to hide themselves. My theory is that you give an ADC and then you give something else and then you move to potentially a different ADC. Now, having said that, I think you do need to change the payload, and I think you do need to change the, the surface marker in an ideal world. And I'd like to see companies develop, ADCs with different payloads, so that gives us a little bit more nuance to it. Having said that, though, I've been thinking a lot about it lately in that triple negative molecularly evolves very quickly. So maybe that doesn't actually hold true for triple negative. And so I'll be honest, I do worry a bit that, whatever you give first line, are they going to get to third line,
exactly.
Right? And so I think a lot of it will depend on, well, what did they get? Did they get the Keynote 522 or are they de novo? And so I think you are going to think a little bit more, I think, differently when it comes to TNBC, and hopefully some of the studies that are out there are going to help guide us. So I think it's not just a question of money, it's a question of, what is the best drug? I'm a big fan of, giving, let's say, nab-paclitaxel. I think it's a really active drug in TNBC. I think, bevacizumab or Avastin is something that...
Yeah, something that we always discuss
discuss. I think we know it's active in the brain. We know that if they've got radiation necrosis, it can reduce the inflammation. We've been doing this for over a decade.
100%.
And outside
100%.
the US, it's still approved to give Avastin. But I think some of the centers now in the US are allowed to give it for radiation necrosis, and it's very active.
I've used it quite a bit, and it seems to be working as well. So let's shift gears to the hormone receptor positive, HER2 negative realm, where again, SG has been approved and is part of the guidelines in those patients who received at least a median line of 2 to 3 lines of chemotherapy. What are your thoughts on using sacituzumab govitecan in that specific setting?
So after first line?
There are at least 2 lines of chemotherapy, and they're endocrine refractory. That was a TROPiCS-02 trial.
Yeah. I think the ER-positive metastatic space has become very complicated.
I agree with you.
Everybody talks about triple negative being heterogeneous. Yeah. I'm sorry, ER-positive breast cancer
is
way more heterogeneous. It represents way more patients, and it's way more heterogeneous. And I think the other thing is, it's going to get very complicated for regulatory agencies, is that the path patients take before they get chemo is equally complicated. So I had a patient the other day, 10 years of endocrine therapy, has never seen IV chemo. She's had every endocrine option. She's had, oral capecitabine, oral vinorelbine, and now it's like, okay, what am I going to do with her? So I think, bottom line is, I think sacituzumab is, one of the drugs that you consider in that space. But when do you give it, and how do you give it? As I said, I think I've been involved in some of the TDXD trials, and I think ADCs are, for patients that don't have a long time on endocrine therapy and progress quickly, are different types of ER-positive, HER2 negative. Mm-hmm. Those are the patients you want to shift up your antibody drug conjugates earlier, especially if you notice the liver function tests are going up, you have one chance. And especially, I find those ESR1 mutants, like before I didn't know who they were, but now I find once someone has an ESR1 mutation, it's almost like they're, I don't know if EMT happens around the same time, but they take on a different course of disease. and
a very resistant course of
well, they are,
disease,
right? And
yeah.
you just cycle through chemos and you even stop scanning them because
Yeah.
it's happening. So that's when you have to say to yourself, no, go to an ADC. Like, you even shouldn't get to chemo. Like, if you notice that your very stable patient has suddenly switched, you should consider an ADC at that point.
So you've actually said something very interesting. So we have the TROPiCS-02, which is telling us that sacituzumab govitecan is superior to physician choice of chemotherapy after 2 to 3 lines of chemotherapy, which is really those patients that are progressing quickly. They've had so much therapy before. But ASCENT-07 was a negative trial because if you see it, these patients first line chemo naive, randomized to SG versus physician choice of chemotherapy, there was no difference. Why is that? What is your explanation for that?
Well, I think there's probably several explanations. So, the first thing could be that, in that first line setting, ER positive, like I said, is very heterogeneous. You don't know the beast you're dealing with, right?
Yeah.
When you're treating after a few lines of chemo, you've selected out the bad players that you were like, I want to treat this. Or under the selective pressure of treatments, these patients have developed more aggressive disease and now it's better than traditional chemotherapy. I mean, the other thing is really maybe in the first line setting is not where it belongs. You know what I mean? Maybe, if you think about the topo-1 inhibitor payload, and if you look at where it might work, it probably works on sort of more mutationally complex tumors. And maybe in that first line setting, it doesn't work as well. So either it's a heterogeneous population, or in that first line setting, they're still, not as complex and maybe don't need something more active. Those are the only sort of 2 theories I have for you.
So you would still be very comfortable using SG in that heavily pretreated cohort of ER/PR positive, HER2 negative?
I think the middle. I think I think any drug later line, it's unusual that it ever works. I would say in the early days of PARP inhibitors, occasionally, because we weren't using platinum, so I'd have the occasional patient on those first phase 1 PARP inhibitor trials. You see a little bit of activity, and I would say that all the new drugs that we have, there's the occasional patient that responds, but the majority of once you're past like X number of lines, you don't usually see a response. So I still think you should not wait as last line. I think you still should do it earlier in the course of disease.
So you brought up the issue of PARP inhibitors and those patients with a BRCA mutation. So if you have a patient with a BRCA mutation, how do you sequence PARP with SG in the triple negative breast cancer setting?
So, and again, it depends on the pace of disease, right? So in a triple negative breast cancer, if they're PD-L1 positive, sometimes you have the BRCA status, but sometimes you don't. But I'm generally in favor, truthfully, of a taxane immunotherapy first line. And that's because I do have a handful of patients who are 5-10 years out. Okay, so there is the occasional patient who just has this exquisite response, even early relapsers who are just very sensitive to immune checkpoint inhibition. And so then what I give, afterwards, if that's say a germline BRCA carrier, I'm more than happy after that to give a PARP inhibitor, and then after that, I guess I'd give sacituzumab. That's probably like how it would work. Now, what am I going to do now that we have a number of ADCs? Well, that was the PD-L1 positive space, right? In the PD-L1 negative space, in that first line setting, the response rates with PARP inhibitors are pretty high, right? So I think I'd probably give a PARP inhibitor first, and then we have ADC options, after that. But
absolutely.
I think the hard thing in BRCA patients is that there aren't as many to do the trials, right?
Absolutely.
So I think it depends on patient's preference as well, right? PARP inhibitor is oral, you don't lose your hair, and the majority of the ADCs, you do see at least some hair thinning, and that's important for patients.
So my final question to you, Rebecca, where do you see ADCs heading in the space of triple negative breast cancer? We've talked about the second line and beyond. Where do you think it's heading in the future?
I'm very keen on seeing in the residual disease space. So when someone gets, neoadjuvant therapy and they have residual disease, can we kind of like rescue those patients, right? Because we know that they have a very high risk of relapse, but is the burden of disease still small enough, like micrometastatic disease, such that we can improve the chance of cure? I guess I'm kind of hopeful as you saw what happened in the HER2 positive space.
Absolutely.
Like the TDM1 style was positive, and then I was really quite amazed that TDXD was as well. So, in that high-risk group of patients, can we rescue patients? And so I'm actually really excited to see that.
Absolutely.
Because one thing we didn't touch upon was that I do think that ADCs, how they work is not just by delivering potent chemotherapy. it's by changing the microenvironment. And so I've started to biopsy my patients after they've had this patient that was on a year on sacituzumab. CPS score was 0 when I started. When I repeated it, it was like
I've seen
35.
that.
I've never seen 35. And so I think you're upregulating STING. I think you're getting increased, expression of all your important immune cells. And so I think it's really important for us to like relook what happens after you expose someone to a particular therapy. And so I think the story's not over in how we sequence these drugs.
So again, not the topic of our conversation, but
we always have so much to talk about.
I know, but I need to ask you one final question. We've seen the results of the ASCENT-03 as well as your DATO trial as well in that first-line setting in the PD-L1 negative patients. Do you think that SG and DATO should now be considered standard of care in the first-line setting, PD-L1 negative or PD-L1 or immune checkpoint inhibitor ineligible patients, triple negative? Do you think we should be considering them now as this is the standard of care for them?
Well, you don't have to ask me. The NCCN guidelines have already included them. I was amazed how quickly that all happened.
Yes.
So as you can see, bottom line is I think the jury is out that everybody thinks that TRP2 directed ADCs belong in the first line setting. I think Dato-DXd, sacituzumab govitecan, I think sac-TMT is an interesting compound as well. So I think to me, it's very clear that they're more active in that first line space. And people spend a lot of time arguing this study and that study. Bottom line is they are both very potent drugs that are active in that first line setting. What I thought you were gonna ask me about is, and this is a call out to everybody out there, where it's really amazing is to see the studies looking at PD-L1 negative patients, looking at giving IO plus ADCs. So we have Morpheus and Begonia.
Begonia, yes.
80% response rates in patients that are PD-L1 negative. So clearly ADCs are actually rendering these patients sensitive immunotherapy. And we only saw early results from the combination of Sazi and Pembro. But I really strongly feel like we should actually look at the PD-L1 negative patients because I think we can truly make a cold tumor hot. That's where I think the excitement should be.
And then, of course, finally, we have results of the ASCENT-04 that tells us Saki plus pembrolizumab is superior to chemo plus pembrolizumab. Should we now consider, in that PD-L1 positive group, should we now consider SG plus pembro to be standard of care? Because NCCN has recommended both, and in fact has given chemo plus pembro as being the preferred option.
Yeah, I think the bottom line is we all think that an ADC plus immunotherapy is the way to go in that setting. Mm-hmm. I think it probably I think we don't have OS data yet, and I don't think we see the true duration of response. I think the missing question here is that we always talk about biomarkers, but to be honest with you, does everybody need it? Probably not. But I think we probably are able to get more people to get a response and for longer. What's really interesting about both the ADC trials that were presented, so the TROPION-02 and the ASCENT trial, is that the duration of response in both of those trials was 5 months.
Yeah.
In triple negative, you can often get a response, but before you do your next scan, they've already progressed.
Yes.
To see that duration of response. And so I think when you're combining IO with ADC, my hope that that's what you're doing is you're rendering more patients to get a response, but then you're keeping them in response. But again, what I'm more interested in is, can you do that with PD-L1 negative? Because I'm convinced in the PD-L1 positive, I'm convinced with just ADCs with PD-L1 negative, but can you combine immunotherapy with an ADC to render a cold tumor hot in those PD-L1 negative?
So thank you, Rebecca. This has been such an interesting conversation. We now know that ADCs are the standard of care in patients with triple-negative breast cancer, whether you're looking at SG or T-DXd or even Dato-DXd. Sac-TMT is already there. But so many unanswered questions. And I think going forward, perhaps at next year's Asia Pacific Breast Cancer Summit, which will be our 15th year.
Join us in Singapore.
Join us in Singapore, and with more exciting data that will try and unravel the questions that Rebecca has just presented today. So thank you very much.
Thank you.